So why does everybody in this room late in the afternoon care about documentation guidelines? It's like, it's pretty dry stuff, right? 85% of the revenue comes from the area that we're about to discuss. We just heard a terrific presentation about effective hospitalist management through a private practice entity that was brought into an academic medical center. Think about it. So that's like FedEx upsetting the United Postal Service. That can happen in the ED. There are three big things that hospital CEOs care about in the emergency department. There are many other things. Number one, is there an internal subsidy? So am I paying out, as the CFO of that hospital, am I paying out more money than the group is generating? Number two, throughput. Is the department moving? And number three, patient satisfaction. We're going to focus on number one. If you're at an academic medical center and you just heard that talk, we should be uncomfortable. That is a private practice solution that unseated a portion of an academic medical practice. So it used to be, it's an academic practice, employed, everything's stable. Canary in the coal mine. So something for us all to really care about. 83% of the typical ED docs RVUs come from 99281 through 99285. Another 8% come from critical care and a little bit from procedures. So that's why we care so much about these guidelines, because they impact 80, 85, 90% of our RVUs. And if you look at the difference between a 3 and a 4, 4 and a 5, look at that. 1.48 RVUs going from a 3 to a 4. And we've had really significant changes from a benchmarking perspective in our 3-4 distribution. 1.61 RVUs going from a 4 to a 5, and then a smaller change going from critical care and an 8-5. All of the scoring of those levels, level 1, 2, 3, 4, 5, they're only based on one big bucket now, medical decision making. And we talked about in the first lecture, there are three kind of elements within that. There's the complexity of the problem, the data, and the risk. And nobody needs to become a coder during 25 minutes late in the afternoon on the first day of the conference. But we're going to come up with some take-home points. In fact, exactly 7. The CPT guidelines that CMS signed off on are 42 pages, and they're highly technical, and there are a bunch of tables and stuff. And what we'll do at the end of this talk is distill them down to 7 teaching points, which are the things that we need to document to empower the coders to assign the correct codes for the complexity of work that we're already performing. On the right-hand side of the slide, that's the 2022 definition of 99285. Look how long it is. I need a comprehensive history, comprehensive exam, medical decision-making of high complexity, counseling and coordination of care, high severity problem. On the left, it's the whole code set. Level 1, 2, 3, 4, 5 takes up about the same real estate in the CPT book, 2023 and now in 2024. And I've got underlined in blue. The only difference between the codes, 99285, high level of medical decision making. 99284, moderate level of medical decision making. 99283, low. That's it. Is it low, moderate, or high? And that's based on scoring these 3 elements that we've touched on. We'll touch on them more. There are significant changes to the benchmarking for the ED codes, level 1 through level 5, going from 2022 to 23 and 24. And there's one very basic reason why. There are a couple of other smaller reasons. The architecture of the code set has absolutely changed. In the middle column here in 2022, levels 1, 2, and 3, straightforward, low, and moderate medical decision making. In the right-hand column, 2023 and continuing into 2024, each of those levels, level 1, 2, and 3, have diminished 1 level in intensity with regard to the complexity of the medical decision making. And importantly, if you look at 99283, it used to be moderate, and now it's low. So anything that scores as moderate is now a level 4. How many have seen a change going from 3s to 4s in their distribution? If you're not sure, it would be good to know. And if it hasn't happened, it really should, if nothing else for this exact reason. Low medical decision making is a very, very low threshold, low cognitive effort. We're talking about bumps, bruises, mosquito bites, no prescriptions, no testing, no x-rays. And that's very few of the emergency departments in this room. And in fact, the AMA has published this data right here. The office codes changed in 2021, and we see now the E&M distribution that the AMA has published, and we see a decrease of 12% in level 3s and an increase of 22% in level 4s. And in the emergency department, we have slightly different codes, but in general, we're seeing the same transition. We'll talk about it. Here you've got in the purple, 2022, the old guidelines. In the blue, 2023, and continuing on into 2024. 99281 is zero medical decision making, zero. So we have almost no level 1s. 99282 is minuscule medical decision making. Large aggregated data, benchmarking data shows almost no level 2s, negligible. Level 3s, they used to run 15, 18, 20%. Most groups in large aggregated data are running 5, 8, 10% level 3s, 5 to 10%. So it's a really meaningful benchmark. If you got 15% level 3s, you might be a unique process where you've got this giant fast track urgent care area, fine. But if you're any kind of typical emergency department, 5, 8, 10% level 3s. And usually that's not what the physicians are documenting. Usually that's the coding methodology that plays a role. Go all the way to the right side of that E&M distribution, 99291, the critical care code, 0.2 to 0.3 times the admission rate. So if you have a 20% admission rate, 4 to 6% critical care would be kind of typical floor. Really organized groups, maybe even a little bit higher. Level 1 trauma center, a little bit higher. 4 MRIs and an MRI coordinator, definitely a little bit higher. And then your level 5s should really stay about the same, and there's as they were previously, assuming we were getting it right previously, and a 5 to 4 split with a little bit more 5s than 4s. A 5 to 4 split with a little bit more 5s than 4s. So you can back into your own E&M distribution. I don't have too many 1s, I don't have too many 2s. I got level 3s, 5, 8, 10%. If you're a very low acuity shop, maybe 10%. If you're a very high acuity shop, maybe 5%. 0.2 to 0.3 times the critical care. If you're a 20% admission place, I'm going to be 4% to 6% critical care. And the rest are split between 5s and 4s. My 5 should not have gone down in my transition from the 1995 documentation guidelines to the 2023 guidelines. And in the end, my 5 should be a little bit more than 4s. My contact information is the last slide. If you have a question about your distribution, totally happy to help. It's an easy process. So what's at stake here? The big picture is the private hospitalist group can be the private ED group that comes and supplants the academic medical group. And that canary in the coal mine moment that you just heard, that's a big deal. Case study, somewhat prepared group, less ready for the 2023 DGs. Coding policies are found to be complex. Doesn't engage resources, there's no in-house champion, the coders aren't fully engaged and updated, and your level 5s go down significantly again. Benchmarking shows the level 5 should not be going down. You should have slightly more level 5s than level 4s. Appropriate 3 to 4 transition, that's simply based on the macro change to the architecture and the coding. That doesn't take place, and I'm down 0.2 RVUs per patient, which doesn't sound like that much, except I'm an 80,000 visit academic emergency department. I collect $40 in RVUs, slightly more than Medicare across my whole book of business, times the 0.2 RVUs per patient, $640,000 a year. Actual green money, not in your budget, not in your lockbox, not available for payroll, annual recurring. So that's why these are so important to get right. So here are the 3 elements, and nobody has to, again, late in the afternoon, become a coder. I've got the number of complexity of problems, the amount of data, and the risk of the stuff that I do to the patient. Do I order a CAT scan with IV contrast, and they have lots of allergies, and it's a very complex process? Do I give them a parenteral controlled substance? Do I escalate their care to admit them to the hospital? Those are all perceived as patient risk things. So let's unpack each of them again at a very, very high level, not granular at all. This first element, complexity of problems. What can I, as a bedside physician, as a leader, as somebody who's pro-education of my physicians, what can I do for my department to move this area forward? Well, the truth is, this area is pretty semantic and it's pretty qualitative. Here are some of the terms as an example. Acute, uncomplicated illness. Acute illness with systemic symptoms. Chronic illness with severe exacerbation. So if I go to an academic medical center and I ask 10 of the attendings, well, what's a severe exacerbation of asthma? I'm going to get a whole bunch of different answers. Admitted, ICU, third line agent, third visit to the ED in a month, uses a rescue inhaler all the time, recent course of steroids. It's all over the map. And so it's really incumbent on your department and your group to develop good coding policies around some of these areas. But as bedside clinicians, what we can do is document a differential diagnosis, the clinical considerations, and the patient's responses to treatment. The guidelines are made by the AMA now. 1995, they were made by Bean County Government CMS. 2023, they're made by the AMA, and they're very clinically focused. Really, we're just supposed to document what we've been doing. So here's an example. 46-year-old male, no past history, presents with substernal chest pain, centrally located, nausea, and diaphoresis while at rest. I've got a nice differential diagnosis, ACS, GERD, musculoskeletal. ED course, serial EKGs and troponins are negative. Pain is relieved by GI cocktail. Heart scores 2, and the patient goes home with outpatient follow-up. Final diagnosis, GERD. And right in these new guidelines is the statement that it's the presenting complaint, not the final diagnosis, that determines the overall severity of the scoring. So that's really important. That differential diagnosis is helpful, and the ED course. If you're in a geographic area with a very high medical legal litigation burden and you're not comfortable with the differential, don't change your practice for reimbursement purposes. You've got the differential in your head. The rest of the chart will speak for itself. If you're in South Florida, you're in New York, you're not comfortable, this is not to convert you to write a differential and change any part of your practice in that regard. The second element, data. Out of the 7 take-home points in the end, 4 of them are right here, and they're pretty straightforward. Did I review an external note? Did I speak with an independent historian? The coders will not know that we reviewed an external note unless we write external note reviewed. The coders will not know that we spoke to the parent unless we document, I spoke to the mother who said X. Independent interpretations, all of us independently interpret our EKGs, but the coders won't know that we're independently interpreting things unless we use that nice language. Per my interpretation, independently interpreted by me. That could be an EKG, X-ray, point of care ultrasound, CAT scan. And then discussions of management or test interpretation, that's your dialogue with consultants. Again, if we don't document it, there's no way that the coders would know that it took place. Now, we don't have to over-document. The goal is to really decrease the burden of documentation. And there's a nice article in Annals not that long ago. The volume of documentation has gone down a lot, almost 40%, about 800 words less per chart. The documentation time is still about the same because I think we're all still getting more and more familiar with our various drop-downs and hard stops and wildcards within Epic. Who thinks their documentation volume is less? I'm just documenting less. I don't need that big macro for the review systems, big macro for the physical exam. Who thinks their documentation time is longer? Couple of hands. So hopefully over time that'll quiet down. Here's what we don't have to document. ED course, 38-year-old female, multiple sclerosis, presents with dysuria, has a low-grade temp 99.5, and in the red box is stuff that's unnecessary. I've ordered and reviewed the results of a CBC, Chem 12, UA, pregnancy test, chest x-ray, and head CT. Chem 12 is normal electrolytes, LFTs, and albumin. Hey, I'm getting points for data. It's unnecessary. The coders can just see the orders. This is an area that's been misinterpreted, I think, by some coding organizations that, well, if you didn't say you reviewed it, then you're not going to get credit for it. You actually get points just for ordering the test. Here's something that's clinically relevant. The white count is elevated at 14.6, UA shows nitrates. I've got 5 to 10 white cells and 1+ bacteria. Okay, I'm going to document that cell. I've got it outlined in blue because it makes a difference clinically to the patient. And then I'm going to hit some of my other boxes in areas that are both clinically relevant and coding relevant. Chest x-ray, interpreted by me, unambiguous, shows no focal infiltrate. You don't need a gigantic full reading, looking at every lung nodule. I did not get trained to look for different grades of lung nodules and which ones need follow-up. I think of our read of the radiologic studies as almost like a fast exam. I'm asking a question. CAT scan, blood in the belly, blood in the head. Chest x-ray, pneumothorax, big giant pneumonia that I need to treat. Sort of a little bit simplistic. I discussed the management with the neurologist, so that's my documentation of a discussion. Agrees with a dose of Unison for this UTI, and we'll see you in the office for a recheck tomorrow. So we didn't need the red stuff, and the blue stuff is an example of a best practice. So what are some other ways to document? I picked an EPIC formatted record. How many on EPIC? Most? How many on Cerner? Pretty good number of Cerner hands. External record reviewed by me, patient admitted here for ACS workup. The patient had an echo. EF was 55%. I can give my fluid bolus. The presentation, 76-year-old, altered mental status, fever and tachycardia, sepsis order set initiated. So here's an external record review. Again, it's really showing the clinical care of what took place, and it's stuff that I was already doing. We're just documenting what we've already been doing. What about these independent interpretations? Normal sinus rhythm, T-wave inversion consistent with the inferior schema. Fine. That's clinically meaningful. I know what's going on there. Doesn't need to rise to the level of a billable interpretation to contribute to the medical decision making. Now, you can't bill it unless it's a robust billable interpretation. But to contribute to the medical decision making, you need a clinically meaningful independent interpretation. We'll go through some examples. X-ray interpreted by me, no infiltrate, no pneumothorax. That is the way I generally approach an X-ray. Per my interpretation of head CT, large intracranial hemorrhage, as seen in the photo on the right. Neurosurgery consult initiated. Most of us at night are independently interpreting these studies. CT abdomen, per my independent interpretation, no free air, no significant hemoperitoneum. It's a little bit more comfortable to say what's not there rather than normal, because we're not always trained to look for every single long-term chronic finding. In a study, we're usually asking a couple of specific focus questions. And what about discussions with external providers, those consults, those discussions of management? Patient with continued pain, repeat exam with focal right lower quadrant tenderness. You can see the appendix lighting up there. CT consistent with acute appendicitis. I discuss with general surgery, admit, request the patient be made NPO, and we'll take to the operating room. So nice documentation. Again, we're just documenting what we've always been doing clinically. All right, the third element, risk. And this is something that's a little bit hard for folks to get their arms around. It's the risk of stuff that we do to the patient. And the AMA has a list of 11 things. Some of them are obvious, like I'm prescribing an antibiotic. I'm giving a parenteral controlled substance. I'm admitting the patient to the hospital. Some of them are less obvious, like I'm considering prescription drug management, but after dialogue with the family, I decide to not treat that bronchitis, that likely viral syndrome. Or the patient has a diagnosis that's significantly limited by a social determinant of health. Again, the AMA came up with these guidelines to reflect our cognitive work. You have an Anthem patient, active PCP relationship, easy follow-up, has a nice home, lots of resources, and they have an early pneumonia. You put them on antibiotics, you know the antibiotics are going to be filled, and you know that they're going to be able to get in for follow-up. Very different than the somewhat homeless patient that doesn't have a car, that doesn't even have Medicaid, that has multiple poorly managed comorbidities, that has an early pneumonia. Very, very different. And the AMA now recognizes and was able to put into the coding grid assignment process the extra work that we do for patients that have these social determinants of health. And we need to say the care was significantly impacted by a social determinant of health. So here are some changes, some new items that if we're not documenting them, the coders won't know. Diagnosis or treatment significantly limited by social determinant of health, and we'll go through an example. Prescription drug management that I considered. but then didn't provide based on some shared decision making. We've got some other areas here that I already mentioned. Parental controlled substances, the coders get that from the orders. Medications requiring monitoring, those are self-evident as well. Decision regarding hospitalization. I'm thinking about hospitalizing the patient, and we'll go through an example with the COPD patient, but they turned around and I'm able to safely discharge them. And then decision to escalate or de-escalate care. So let's go through some examples here. Diagnosis or treatment significantly impacted by social determinants of health. Here's my clinical example, 28-year-old with dysuria. UA shows nitrate positive, 2+ bacteria. Pregnancy test is negative. My plan, outpatient antibiotics. But I talked to the patient, recently unemployed, and without health insurance to cover treatment. So what do? We pivot to my wild card there, discussed with pharmacists, verified patient's medication will be $4 at the hospital pharmacy. And then underlined, I've got my clear statement. Patient's care was significantly impacted by a social determinant of health. I did more work. The patient needed that. It was very, very clinically relevant. All the good antibiotics in the world that are written in a prescription don't help if the patient's never able to get them and fill that prescription. We're going to go through two vignettes, a low acuity vignette and a high acuity vignette. 15-year-old, 2 to 3 days of non-productive cough, also complains of sore throat, no known sick contacts, good clinical information, no change in appetite. The mother adds he had a fever yesterday to 100.5. So that's my independent historian, very clear, calling it out. I do a COVID and a respiratory virus panel, which are negative, and then document my clinical thought process that was always taking place. Clinical condition consistent with viral etiology. I discuss with the mother antibiotics not indicated as the likelihood of a bacterial infection is low. And that's my consideration of prescription drug management, which leads to the complexity of the care that I'm providing and the coding process. So let's look at a high acuity vignette. This is going to be very concrete. Same presentation on the left side, same presentation on the right side. I've got a 52-year-old male with COPD, presents wheezing and tachypnea, received several rounds of NEBs, CBC, Chem7, chest x-ray is negative, and the patient ultimately improves. Disposition, discharged home with primary care physician follow-up. So it's a little bit of a bland record. From a risk management perspective, it's really not fabulous. Now let's use all the tools. 52-year-old male, COPD, same exact presentation. I'm going to perform that independent interpretation of the chest x-ray, which I've already been doing. Now I'm going to document it. Chronic changes, no infiltrate, that's what I'm looking for. I'm going to review the external notes, which is good clinical care that I've always been doing. Now I'm just going to document it. Prior admission, O2 sats, 92%. And what happens with these patients? Well, the note on the left sort of blurs all the care together, and the note on the right shows the evolution of the care. Patient reassessed, still with moderate wheeze, may require admission, may require observation. Continue NEBs and reassess, then you reassess the patient a second time. Disposition, discharge home, primary care physician follow-up. On the left, more consistent with a level 4, same exact care, not well documented. On the right, documenting what we've always been doing, more consistent with a level 5. Different documentation process, same care. So if we take the 42 pages of that technical stuff in the CPT manual that correspond to these new guidelines, the first time we've had new guidelines in 28 years, we can distill them down to 7 things that as a leader, as somebody who's responsible for the finances, or as a bedside physician, that if I don't document them, the coder won't know them. Number 1, discussion of management with other providers. Could be hospitalist for an admission, could be a consultant, GI, neuro, social work, could be speaking to the primary care physician to make sure that follow-up is available for that patient. My independent interpretations, we want to use clear and unambiguous language, independently interpreted by me. EKGs, plain x-rays, CT scans, ultrasounds. Again, at night, more and more of us just read this stuff on our own. Review of external records. That's any record that's not from your emergency department. So it could be an inpatient hospital record, an office record, nursing home, EMS. History obtained from an independent historian. I gave an example of a parent. Prescription medications or testing, that's considered antibiotics, antivirals. We went through a vignette there. X-rays, CT scans, 2-year-old bumps the head. PCORN criteria not met, no CAT scan performed, shared medical decision-making with the parent. Care affected by social determinants of health, we went through an example there. What percentage of visits in the country, the whole country, in the emergency department, out of 140, 150 million visits are impacted by a social determinant of health? What was the number? Yeah, about 15%. So we did a really good study. I had the pleasure of collaborating with the Yale Scholars Group, and we looked at zip codes where 20% or more of the population was below the federal poverty limit. So that's a single person making less than $11,000 a year based on that state. And the documentation of social determinants of health was like 2 or 3% because nobody's sort of been aware of it. And I think one thing that's important is as we consider social determinants of health, we're creating data then in the diagnosis code set. There's a little bit of a tangent for a moment. That allows resources to be identified for our patients that need them. It also allows resources to be identified for our hospitals, our communities, and our counties that need them. It's almost like mini census data where, oh, I only have 2% social determinant of health patients, therefore I don't need much grant money. Well, actually, it's probably the opposite. You probably have 10 or 12 or 14 or 15% social determinant of health patients, and they end up in a diagnosis code, and that diagnosis code is in a national database, and it can be used for advocacy to both identify the patients that need to be pointed towards resources and your hospital, your health system, and your community that need state and federal funding. So that's another way to think about it. And that's the way the rest of the world uses the diagnosis code set. It's only in the United States that we use it for all this reimbursement stuff. Appropriate consideration of hospitalization, those are your chest pain. We went through a COPD example. And again, my contact information is here, and I'm here throughout the day and for the reception. Thank you very much.